Welcome everybody to the joint Oregon, Washington, Alaska virtual conference. So we're excited that you can join us today for some great education and fun. Don't forget to join us tonight for our networking challenge against Washington, Alaska, Family Feud Throwdown, where Oregon is attempting to take back our trophy from Washington, Alaska. I want to thank you to all of the volunteers who helped put on the virtual conference. We could not do this without you. If anyone is interested in getting involved with either the Washington, Alaska or the Oregon chapter, please use the chat feature to let us know you're interested. And then save the date. Next conference is September 17th. So this session is sponsored by Merchants Credit Association. Merchants Credit is a premier full-service debt collection agency providing successful debt management solutions with integrity since 1937. Merchants has become a leader in debt recovery by dedicating decades of service to companies and communities. Their commitment to serving clients in an ethical manner, longevity in the industry, and vast institutional knowledge produces exceptional recovery results. Merchants Credit is structured to provide full-service, professional collections across large and small business sectors. Thank you, Merchants Credit, for your ongoing support to the chapters. This session is 2021 Medicare Regulatory Update for Hospitals, Proposed Rules Updates by Paul Holden and Jonathan Mason from Moss Adams. A little bit about Paul. Paul's been in public accounting since 2003. He provided reimbursement consulting and business assurance services to healthcare providers in acute and post-acute settings throughout the United States. Paul's well-versed in preparing Medicare and Medicaid cost reports, assisting clients during third-party audits, formulating appeals of audit issues in connection with cost reports, and assisting hospitals and health systems. Sole community hospitals, critical access hospitals, rural health clinics, and federally qualified health centers with billing and reimbursement issues. Paul understands the nuances and complications of the role reimbursement has on the longevity of the health organization, specializing in errors, especially if errors are not corrected. He explores the role of Medicare cost reporting and data claims of DRG and APC rate setting processes, wage index cost finding, and labor market definitions with a focus on wage index reform and Medicare cost reporting data mining and benchmarking. Paul's a frequent speaker and author sought out by his reimbursement expertise. We've seen Paul before, and we're happy to have you back, Paul. Jonathan Mason has worked in the healthcare finance since 2004 with a concentration in government reimbursement. He focuses on Medicare DSH and Worksheet S10 engagements for hospital clients ranging from small to rural facilities to large hospital systems. His experience includes preparing Medicare DHS and Worksheet S10 data for internal and amendment cost reporting findings, reviewing and drafting hospital financial assistance policies, and overseeing Medicare DHS and Worksheet S10 audits and appeals. Since 2017, Jonathan and his team has completed over 850 fiscal years of detailed Worksheet S10 reviews for 256 hospitals in 32 states, as well as participated in over 245 audits. He and his team has also completed thousands of Medicare DHS engagements for hospitals across the country. He regularly presents on the IPPS, Medicare DHS, and Worksheet S10 topics. We're excited to have Paul and Jonathan today with us, so please welcome Paul and Jonathan.
All right. Well, good morning, everyone. Thank you, Tammy, so much. Always great to be back with the Oregon HFMA group here. A lot of familiar names and faces on our attendee list, and we're great everyone can attend in this virtual environment. Today, as Tammy mentioned, we're going to be going through the IPPS Prospective Payment System proposed rule for 2021. This is a very unusual year, as Jonathan and I will tell you as we go through this. It is now August the 20th, and CMS still has not issued the final rule that will be effective for October 1st, 2020 for the 2021 payment system. Typically, that is issued in early August, or at least the data files and tables are, because of all of the logistics and housekeeping that need to be done before the new federal fiscal year begins. So we will certainly update the Oregon group on developments with that. Jonathan, I think as you will find or share with the group, and we've found that there were a number of areas in the proposed rule that I think CMS is going back and revisiting in this rulemaking, especially their retroactive interpretation on Medicare bad debts and certain other items. So we'll talk about those in this presentation. We have 90 minutes together this morning, so certainly want to leave adequate time at the end of the presentation for a Q&A, but also want to make sure that we're sharing with you all what we're seeing in this latest rulemaking. One thing as a reminder, as we're talking about this presentation being the IPPS focused rule is on Medicare Part A. And one thing that we are definitely seeing in terms of the evolution of the Medicare payment system is that Medicare is no longer Medicare. With the continued expansion and evolution of Medicare Part C, the managed care plans, and how those managed care plans are leaning heavily on Part A rate setting, it really puts the provider in a position to make sure that any information that's coming out from government payment systems for IPPS, OPPS, Medicare physician fee schedule, that your reimbursement, finance, revenue cycle, and payer contracting teams are all working in unison during the year, because we want to make sure that nothing gets lost in translation, especially as Medicare continues to navigate this COVID minefield and finds new areas to identify either HCPCS codes, ICD-10 codes, or other ways to reimburse payers for uninsured and uncompensated care. So it's remarkable now. It's not just a matter of trying to understand whether or not payment rates are going up or down, but truly understanding the nature of the payment rates and how those affect all payers. So on our agenda today, we will talk about those payment rates. We're going to touch on medical education. We're going to talk about MSDRGs and how those continue to grow and evolve and how the cost report plays a role in that. We'll talk about other hospital programs, specifically value-based purchasing and those types of quality-driven care. We're going to touch on pricing transparency. As many of you saw, there was a district court decision a few months ago. Pricing transparency is front and center right now with HHS, CMS, and the provider community because of how hotly contested it is to have this level of transparency and understanding out in the marketplace. We'll talk about Medicare bad debt and what CMS and the contractors are trying to do in that area. We'll talk about wage index and where that's headed. We actually just saw a recent publication that CMS is putting wage index reform back on the table in some way, shape, or form. And then Jonathan is going to share his expertise on what we're seeing with Medicare DISH and the UC pool. And then we'll close out with Q&A. So quite a bit to get through this morning. With regard to payment rates, as many of you remember, we have a market basket update system. Currently, through the proposed rule, CMS is estimating an increase of about 1.6% to the market basket. As a reminder, the full market basket adjustment is available to hospitals who are meaningful users of EHR and have submitted quality information to the CMS system. Otherwise, there's a sliding scale if you do not submit quality data and are not a meaningful user, which I think is going to be maybe the bottom 0.5% of providers out there, where you would actually have a negative market basket adjustment in that particular year. CMS uses what's known as a Lesper's type market basket update. The Lesper's type market basket adjustment is similar to a consumer price index, where CMS takes a basket of goods and services and measures those same goods and services over a period of time. It'll be very interesting to see as we see a continued evolution of all of the different pricing and costing practices that hospitals are going through as we look at major generational shifts, especially in nursing staff and other metrics, how the cost of healthcare is going to change and how CMS will continue to modify the market basket to keep up with that cost shift. So currently, as proposed, the payment rate is going to be increasing from just over $6,200 a discharge for a DRG weight of 1, all the way up to just over $6,400 for a DRG weight of 1. As we can see here, the payment rate is always the same, whether or not your wage index value is greater or less than 1. It's the mix of labor and non-labor related costs that shifts between the two, and capital reimbursement remains the same. As we've talked about in years past, the capital reimbursement line outside of the operating DRGs relies heavily on worksheets A7, B Part 2, Column 0, and other worksheets in the cost report that reflect depreciation, interest, and lease and rentals for the hospital community. And so CMS uses that information to determine how much capital reimbursement hospitals should be receiving. So you want to make sure, even though in many cases those worksheets contain relatively simplistic general ledger information, you want to make sure, especially if you've done a large hospital expansion project or if you've shipped from capital leases to operating leases, that you're still capturing and reporting that information, because that's the only source of truth for CMS in many cases on how to understand where they should be prospectively reimbursing hospitals for their capital structure. Each year, the advisory board goes through and takes the information from the proposed rule and pushes it through the various DRGs on a service line level. So we always like to share this slide because while the 1.6% update is overall an average of the increase, we can see that in many cases, service lines across the DRG population benefit some more than others. And many times this information is completely dependent on the information from the MedPAR data set, as well as the cost report information available at that point in time. So these types of analyses are shared mainly to emphasize the point that when providers are making changes in their cost report, that they are still using the prescribed forms and cost centers that CMS has put out, because they use those prescribed cost centers to make these DRG determinations and also APC determinations on outpatient. So it's so important that if you are expanding services, especially in the surgical disciplines, in cardiovascular rehab, if you are either expanding or contracting your provider-based clinics, that it's really important that you're making sure to use all of the correct lines, because CMS relies on those cost center definitions in order to make these determinations. And with that, Hayden, we'll move to our first polling question. The first polling question, when Hayden populates it here, is to ask, do you or your team regularly review CMS's IPPS rulemaking? And we're just keeping it easy for this first one. Yes, no, or if you are unsure. Very good. Looks like we'll give folks just a few more seconds to respond. Perfect. All right. So it looks like the majority of everyone is reviewing rulemaking for sure. Hopefully everyone can see those poll results. That's always encouraging to see. As Jonathan and I will tell you, it is amazing the volume of rulemaking that comes out from CMS. Oftentimes we're solely focused on IPPS, OPPS, Medicare physician fee schedule in the hospital community within HFMA. But with all of the other rulemaking that comes out, especially on the post-acute side, home health, hospice, ESRD, skilled nursing facilities, IPF, IRF, all of those different areas, it is so critical to make sure that those folks out there are reviewing those. And it is amazing. I think it was several years ago, what CMS did is they ran out of time to get something into the IPPS rule. So they buried a change for Medicare bad debts in the end-stage renal disease rule. So oftentimes Medicare will try and get everything into the rulemaking, but sometimes they will put it in other rules. So it's always important for those folks who may be unsure on the call, definitely take the time to go out to CMS's website and review those rules. Usually CMS's website's fairly easy to navigate, but good exercise for sure. So with medical education, a couple of things we wanted to mention here in the from the proposed rule is the proposal to expand the existing definition of who's considered a displaced resident. So those are solely focused right now on residents who are physically present at the training hospital on the day prior to or the day of the hospital program closure, allowing for greater flexibility for the residents to transfer while the hospital's operations or program is winding down. And CMS is also working to allow funding to be transferred for certain residents who are not physically at the closing hospital or closed program. Something to mention here with GME is GME continues to be an area of significant discussion for providers nationwide, mainly because we're getting to a point with many programs. We see it some in the West and heavily in the East, where there are a lot of programs who have finally decided that their programs are just no longer sustainable. The amount of Medicare reimbursement that they're receiving for the total cost of the program is not sufficient. And so many hospitals are either deciding to close the program, or in some harder hit communities, the whole hospital is closing along with the program. So we want to encourage folks continue to actively review Medicare's GME policies, mainly because between affiliation agreements, closing hospitals, and slots that may be available, there are many hospitals throughout the country where your FTEs that are currently reported on the cost report are well in excess of the FTE cap that was set all those years ago. So we're seeing as this continues to be a greater and greater focus from CMS, we anticipate that CMS will continue to put out more guidance on this. Obviously, as we look out to 5-10 years from now, the ability to train physicians in the hospital setting, mainly on the DO and family practice side, I think CMS is going to have a heavy focus on that, making sure that residents are still having adequate opportunities at hospitals nationwide to be appropriately trained prior to going into the full practice of medicine. When we're talking about the DRG updates as well, we've got a new DRG for CAR T. As many of you have seen, immunotherapy is a big issue right now, big dollars at stake. And as immunotherapy and other oncology and especially bone marrow transplantation, stem cell therapies, as these continue to evolve, CMS is trying to get as much data as possible through the cost report and the MedPAR claims data in order to make sure that they're adequately reimbursing providers for these therapies. So right now, we finally have a new MS-DRG that's specifically for CAR T. I know that this is going to be an evolving discussion, heavy emphasis as well between IPPS and OPPS. But we just wanted to make sure that you were all aware of this, knowing just how much the cost can be of some of these immunotherapy treatments, to make sure that the prospective payment is picking that up. With hospital-acquired conditions and the readmission reduction program, typically with these, we're also still focused on CMS's emphasis on quality care, really looking at making sure that if information is going out on the claim form for either a hospital-acquired condition, or making sure if the Medicare beneficiary is readmitted to the hospital, making sure that that information on the claim form is appropriate and properly stated. We're seeing that what CMS is continuing to do, and we've highlighted here, is they often continue to look at the measures, the conditions, and the acuity of the patient with those types of programs. So something just to be aware of, that between value-based purchasing, hospital-acquired conditions, and readmission reduction, that those are still front and center with CMS, even though in many cases we're talking about a payment differential or plus or minus only a few percentage points, depending on the volume of your Medicare Part A business, that could translate to a significant amount of lost reimbursement. As we mentioned with pricing transparency, this continues to be a hot button issue. I think what we're seeing right now is there's a continued emphasis from the provider community that in many cases, even if charges are posted out to the website, it's often difficult for the patient community to interpret and understand what those charges mean, how those translate to line item charges on their bill. And in many cases, what I've heard from providers that I've discussed with this is that their concern isn't so much that the patients are going to be fully understanding this and being able to shop around, which is the intent of pricing transparency, but that other entities such as payers and other organizations will be using this to either their detriment or advantage. So not too much time to spend on this, but we did want to highlight the fact that pricing transparency was still in the proposed rule. As we saw in June, there was a court decision to leave it on the table. So I think between HHS, CMS, and the provider community, I think that we're still going to see additional discussion of this in the final rule, and we'll see what they're putting on the table to begin January 1st of 2021. Talking about Medicare Bad Debt, we wanted to highlight a couple of different items in this. This is a very unusual stance that CMS is taking this year. They are anticipating that they want to retroactively as well as prospectively change the definition of how Medicare bad debts need to be reported in order to be reimbursed. One thing we wanted to highlight on this that's very unusual, and Jonathan, I think you and I are seeing this in some other areas as well, mainly with the decision in the Alina case around Part C days being included in the SSI ratio, is that in the Social Security Act, back when this was developed in the early 80s for the DRG system, CMS's mandate was that they could only change the prospective payment system prospectively. They could only go forward. That's why entities such as recovery audit contractors and ZPICs and the OIG and others had the ability to go back and retrospectively recoup dollars because they had the authority to go backward, where CMS through the DRG and APC systems were only going forward. So something that's very important to mention to you all in terms of Medicare bad debts, and you can read the various bullet points, but something that I want to highlight here especially is that we are seeing through many of the desk reviews and audits that we're working on with the provider community that Noridian and other Medicare contractors are going back, they're going to the provider reimbursement manual, and what they're saying is, especially with regards to charity care bad debt, where you had a Medicare Part A beneficiary who received financial assistance or charity for their either deductible or coinsurance, is that the providers in some respects had not gone back and determined whether or not the beneficiary had the ability to liquidate other assets, or that the hospital really thoroughly vetted the opportunity for the patient to come up with the money to meet their obligation. And so that is something that we wanted to mention to you, and we're talking about here, especially on this second bullet point, is that providers are being put in a position where you don't necessarily have to force the patient to liquidate their resources. But what Noridian and other contractors are looking for is through that charity care application, and they're wanting to go retrospectively with this interpretation, is that beyond a tax return, beyond clarification that they're on supplemental security income, that they only provided a pay stub or a bank statement, They're really wanting to see that the providers went through and vetted that process out. And in many cases, they are disallowing Medicare bad debts through the desk review and audit process because they're not seeing in the charity care application that the providers went to those lengths to make that determination. So something just to make you aware of. Some of you, many of you may have already seen this in your interaction with the contractor, but we wanted to highlight this, that now CMS is trying to go through the rulemaking cycle and memorialize these types of determinations. So something just to keep front of mind, working with your business office teams, that if you can go back in preparation for future desk reviews, take a look at your charity care information, take a look at the language that was in the charity care policy. In some cases, there were hospitals that even if they didn't necessarily maintain all of the documentation, there were checklists within the charity care applications where hospitals noted, do you have a second home? Do you have any recreational vehicles? Do you have other items? So at a minimum, they were at least asking questions, even if the follow-up was not necessarily provide documentation or proof of these certain items. And then ultimately, it's going to be up to the contractor and the auditors as to whether or not they will accept that as sufficient. And one thing I think we're seeing, and I know Jonathan sees this as well with DISH and UC and other items, is that often many times you can get a different answer from different auditors at the same contractor. And so oftentimes it really comes down to understanding the rulemaking, understanding the provider reimbursement manual, and having that information available when they go to make those determinations. So lots of continued changes there. As we've seen, Medicare bad debt has been an area of priority for the government to try and wind down for many years. Critical access hospitals several years ago were still getting dollar for dollar bad debt reimbursement. We're now down to 65 cents on the dollar for all provider types. In many presidents' budget proposals, we've seen that they want to reduce Medicare bad debt down to 25% of deductibles and coinsurance. That was more prevalent during the Obama administration when they were trying to find ways to fund certain ACA programs. They were trying to put a heavier emphasis on reducing the amount of the Medicare bad debt percentage. But we want to encourage all of you that as you're going through and looking at crossover bad debts, charity care bad debts, or even those that have been returned from an agency, if there's an opportunity to either report them on the current year's cost report or go back and reopen or amend prior cost reports, take advantage of that opportunity to do so before CMS finally decides to wind down this reimbursement opportunity altogether. So we'll also see that I think there's continued emphasis on crossover as well. In certain states, one of the issues has been with some of the Medicaid managed care plans that the denial EOB information coming from Medicaid managed care in order to support that crossover has either not been readily available or has not been in an audit compliant format. We've seen this mostly in California, but I've seen it in some other states as well. So just making sure that whether it's Medicaid fee-for-service or Medicaid managed care, that you're able to support that denial EOB amount, especially if it's in a unique arrangement like capitation or some of those other areas. There's additional nuances based on how the contracting language is laid out. So with that, what we'll do is actually move to our next polling question, Hayden. And with all of that discussion on Medicare bad debt, our question to you, do you feel that your hospital is capturing all allowable coinsurance and deductibles on your annual Medicare bad debt reports? Give folks just a few more seconds here. Perfect. All right. So fairly evenly split, and this is almost exactly where I would have anticipated it coming in. Great to see those folks who are comfortable in that. For those folks who are no or unsure, definitely an area where you can be in the driver's seat actively working with the revenue cycle teams, making sure that all of that information, whether it's in a current or prior listing, is adequately and appropriately stated. The one key area with Medicare bad debt reporting is when the contractors sample those listings, whatever error rate they do come up with, because they use a statistically valid sample, they do extrapolate that error. So oftentimes what we encourage providers to do is that if you've submitted a listing and you have time between the time of the as-filed cost report and the desk review, that is the perfect time to go back, work with your teams, make sure that you're all comfortable with the listing. And if a revised listing needs to be submitted to the contractor prior to the desk review, that is the time to do it, because they will sample from the final listing in most cases of what you send. So if you find that there's maybe, say that anywhere from, $500 up to $50,000 of accounts that either need to be on a different year's listing or just did not meet the criteria, that's the time to get those off the listing so that they do not extrapolate that error rate. So with that, we'll talk about the Medicare wage index. There's a lot of activity going on with the Medicare wage index, and a couple of things to be mindful of. The biggest item that's coming up with the wage index right now, and you all have seen a lot of reminders about this from the federal government, is we're in the middle of a census. And so every 10 years, there is a reshuffling of the deck, and we are in the midst of that now. We anticipate that the results of the 2020 census will be released at the end of March of 2021. And especially in the Northwest, we have seen a lot of areas of our states in Oregon, Washington, and otherwise. There are areas that 10 years ago truly would have been considered rural. And especially here in Oregon, I mean, if you're in downtown Portland and you start driving out on Highway 26 toward the coast, 15, 20 years ago, you could get 10 miles out of town and think that you're already in Seaside. And the urban sprawl that has occurred out into the suburban areas, especially in Metro Portland. We know that Central Oregon continues to grow. Down the Willamette Valley, the expansion of housing has exploded as well. So we anticipate that in many areas of the country, that those CBSAs that used to be in the rural CBSA, or even certain areas that may have been folded into their own CBSA, may actually end up combining or splitting apart depending on population growth. So that's something to be aware of, is that while the wage index is solely dependent on that, there are all kinds of other areas of reimbursement that are affected by the census. If you're a sole community hospital that's in a rural census tract of an urban CBSA, that potentially could be in jeopardy. So as you're planning out to your 1, 3, 5-year short-term and long-term strategic plans, make sure you're aware of all of these other activities that are happening at the federal and state level, because it may impact wage index or some of these other standard reporting items, but it also could affect the nature and designation of your hospital as well. So with the wage index, we wanted to remind the group that the adjusted wage index, and by adjusted, we mean those wage index values that are adjusted for things like the Occupational Mix Survey and other items, are used for IPPS, OPPS, and even some state-level programs like California Medi-Cal, fee-for-service. They also factor into the OHA fee-for-service payments as well here in the state of Oregon. The unadjusted wage index, though, is used for our skilled nursing facility providers, IPF, IRF, and also ESRD, home health, hospice, and others. The reason why we highlight the fact that there's a difference between the adjusted and the unadjusted is that while hospitals have the ability to reclassify themselves for payment purposes from their home CBSA to a neighboring CBSA, the wage index values that are developed in that specific CBSA affect the providers mostly in those post-acute settings, and those post-acute providers do not have the ability to reclassify themselves from one geographic area to another. So it's so important as you're going through that process to recognize that all boats rise in these equations, and that hospitals who are in the same CBSA and those post-acute providers, that you're all working in unison to make sure that there aren't any unintended consequences with that. So in terms of last year's wage index update, we wanted to make sure that there were a couple of items that are still front and center in this year's rulemaking that originated last year. The first one being the rural floor, that CMS decided to exclude urban hospitals that have been reclassified as rural from the development of a true rural floor, that the true rural floor is actually being based on those hospitals who are staying in the rural CBSA, so that we aren't muddying the water between those hospitals that are in versus out. Also, the other item is this wage index change for the lowest quartile hospitals. There was a lot of discussion in last year's final rule and proposed rule about the average hourly wage in California versus the average hourly wage in Alabama, and CMS's intent to try and bring all hospitals closer to center. And that's where this temporary stop loss of a 5% cap decrease was, that if we're bringing down the highest quartile and we're bringing up the lowest, that the most that CMS would take out in any given year in terms of scaling that change would be at most 5% year over year. So we do continue to see that into the 2021 rulemaking. There's a lot going on here that you all can read through. But the biggest item here is that CMS continues to revisit the wage index by trying to find ways to create equity in this system, either due to hiring patterns, labor shortages, or labor markets. So every year with the wage index, they're taking salaries, benefits, and contracted labor, and also trying to make a determination based on hiring patterns for RNs, LPNs, and others. For many of you who have already completed your Occupational Mix Survey, CMS is continually trying to find ways to create equity where either if you hire a predominance of contracted labor versus employees, if you have to have a lot of registry or traveling nurses, or whether or not you have a large corporate or regional home office and you're sending down a lot of contracted labor or other costs from the home office, these are areas that CMS continually reviews because they want to make sure that we aren't unfairly reimbursing one hospital versus the other. But as we know, the cost of labor in Portland, Oregon versus Los Angeles versus Paducah, Kentucky is all very different. And so what we see CMS continuing to revisit is whether or not doing these state CBSA and other designations versus actually getting down to a wage index factor that is more specific to the hospital is fairly reimbursing providers. So just something to be aware of, that there is continued discussion on trying to determine whether or not the system as is appropriate. One thing to be aware of in this rule, even before this change from the upcoming census, is that in this 2021 rulemaking, you can see there were a number of changes. 34 counties are converting to urban to rural. 47 counties are converting from rural to urban. 37 new counties are qualifying for a Lugar designation, which means that they are geographically rural, but they're deemed urban based on their proximity and commuting patterns. So while you may have a county that's theoretically rural, a predominance of employees are actually living there but migrating to and from an adjacent area. And then also 19 counties that would move to a new or modified urban area. As I mentioned, sometimes population growth in a certain core-based statistical area can grow so much year over year that CMS makes a determination to pull those apart. The last time we saw that here in Oregon is when they created the new Albany CBSA and pulled that away from previously being included in another CBSA. So a lot of changes going on here. So Medicare continues to tinker with this system, and I don't think that we're going to see this going away anytime soon. So certainly for those areas navigating to this section of the IPPS rule is very important just to be proactively managing whether or not the area that you're located in may have changed in terms of CMS's designations. As I mentioned before, with these, we're always conscious of the fact that these geographic designations affect multiple provider types. And certainly, as we know, critical access hospitals and the critical access hospital designation, whether meeting the federal or state criteria, has continued to be front and center with CMS. As we have seen, there are critical access hospitals in certain markets that have ended up in geographic regions that have had population growth and ended up in an urban area. And so CMS is allowing a transitional period for those critical access hospitals in order to be able to either stay or change, but they want to make sure that if you're going from rural to urban, that all of a sudden that next year you're not going from cost-based reimbursement to full PPS. They are allowing for a transition period with that. And it will be interesting to see as time goes on and the effect of many of these programs continue to change, whether or not CMS finally gets around to taking aggressive measures and really putting the federal critical access hospital criteria as the main driver and eliminating those critical access hospitals in terms of payment designation that were eligible under the state criteria. And I think as we've seen, Oregon, there are a few areas of the state that would be more at risk than others. Same with Washington. Usually what happens is when they're making changes like that, they're looking at states like Missouri, where you've got dozens and dozens of critical access hospitals, essentially all in neighboring areas. So not as quite of concern out west, but always a concern when we're losing potential reimbursement optimization. And with that, Jonathan or Hayden will actually move to our next polling question here. So this polling question, do you regularly consider the financial impact of your wage index factor on non-acute settings such as SNF, IRF, IPVS, home health, et cetera, and those payments other than Medicare inpatient and outpatient? Very good. Thank you, Hayden. Yep, I would say that's about what we would have expected as well. Oftentimes, this doesn't become as much of an issue until some of our providers in the post-acute setting realize that there was a major change from one year to the next. But just something to be aware of if in your labor market you're seeing a major transition, if there's a big change in hiring patterns or the average hourly wage, and the effect that has on wage index values, just know that the changes go well beyond the acute care providers in that community. Right. So as many of you have either submitted or are in the process of submitting, we are in the midst of our 3-year Occupational Mix Survey window. As I mentioned before, the intent with the Occupational Mix Survey is for CMS to set a new baseline for providers nationwide and get an understanding of the hiring patterns for acute care hospitals. They want to know on the distribution of nursing staff, what is that mix of RN versus LPN versus CNAs and MAs, because they want to gauge if certain states or certain regions of the country are hiring more of a certain higher cost labor type. They use that then and reflect that in the final wage index values to bring some areas up and some areas down, because they want to make sure that in some states that if there is a predominance of higher cost RN staffing and CMS believes that those hospitals had the option of using lower cost nursing staffing, that essentially they're quote unquote penalizing certain areas of the country. But as we know, that is completely dependent on all sorts of different areas that are well outside the control of the hospital in some cases because of nursing unions, minimum staffing ratios, acuity of patients, trauma centers versus tertiary hospitals. There are all those designations that sometimes in CMS's effort to normalize payments, they don't fully vet out the operating and clinical requirements of the hospitals in consideration of that. So going through here, we are right in the thick of this, actually, with just a couple of weeks to go here for both the occupational mix and wage index corrections, making sure that wage index corrections are submitted by the 3rd of September. Occupational mix surveys can be submitted by the 3rd of September. CMS did give an extra 7 days on the occupational mix in case you need to go back to the contractor and make any final revisions. In November, state hospital associations will be notified as to whether or not the hospitals did not submit any wage index queries. And then as we see, typically the cycle is we get through our wage index corrections in early September. The contractors start reaching out in late September, early October. And then as we get into the early part of the year, Noridian and other contractors have made those determinations. They've worked with the providers to get as much information on contract labor, salaries, and benefit core costs. Those files are released. And then in January, February, and March, those are the times where they submit the preliminary listings. It is a very, very, very important, and I can't overemphasize the word very. It is very important to make sure that any corrections, positive or negative, that have been communicated to the contractor, that the contractor has adequately and appropriately communicated those changes to CMS. We have seen many times where final changes that are happening at the very last minute, where contractors are agreeing to include certain amounts of contract or other labor costs, they didn't get that final communication in there. And that file in February is then transmitted in March that is used for the next year's IPPS proposed rule. And you want to make sure that if you have that time to review those documents, making sure that that's included for that proposed rulemaking. It is so important to also remember that February and March review period of confirming the changes does not allow the provider to add anything further. It's just making sure that whatever was finally transmitted is actually being reflected at CMS's level. And then it's going to be hard to believe that we'll be into 2021. Hopefully we haven't moved on to COVID-20 by then, and that life is returning to somewhat normal or back to normal. And with that, what I will do, as we're about at the halfway mark, is I will pass it over to Jonathan to share with us on Medicare DISH and UC.
All right. Well, thank you, Paul. I think we'll spend a good portion of the rest of the time, kind of like Paul mentioned, diving into this UC payment section of the rule, kind of understanding how the pool size was determined and ultimately the calculation proposed to distribute the funds to those Medicare DISH eligible hospitals. So I know that some kind of on the call are very familiar with the overall objective of the UC payment program and kind of how it's changed from that pre-OCA formula. But we'd still like to take a couple minutes, kind of set the stage for everyone listening, especially those on the call or who are not necessarily involved in the kind of payment formula on a day-to-day basis. So the size of the UC payment fund is first determined by two factors. Factor one is the difference between an estimate of what would have been paid to qualifying hospitals under the historical DISH formula and the 25% of empirically justified amount. So the source of these estimates is the most recent available projections of Medicare DISH from the CMS actuary. It's the most recent filed cost reports and most recent DISH data from the IPPS impact file. So if we can go to the next slide, we'll kind of dive a little bit more into how this factor one was created for this 2021 calculation. So the DISH estimate begins with an anchor period, and in this case, it's the 2017 data, which is then trended forward by a number of factors applied to the 2018 through the 2021 periods. And so as you can see on this slide, there's quite a few adjustment factors, and I'll just briefly touch on all of them. There's an IPPS update factor, there's a discharge adjustment factor, a case mix factor, Then there's something called an other adjustment factor, which actually historically has not been given a lot of visibility in the rules published by CMS. So just kind of beginning with that IPPS update factor, you can see that it starts, as it goes down on this slide, you can see it starts with actually a market basket update that's published each year, and that includes an OCIT payment reduction factor through 2019. It's got a productivity adjustment factor, and then there's a documentation and coding adjustment factor, and that's all for that update factor. And then just going back to that discharge adjustment factor, that represents the number of Medicare fee-for-service inpatient hospital discharges. And so actual data is used where available, and then projections are used for the more current or other years. And so moving on, you've got the case mix adjustment factor that shows the increase in the case mix for IPPS hospitals, and just like in the discharge where available, the actual data is used, and then they'll use an estimate on the rest. And finally, when you get to that other adjustment factor, what that includes and what we can tell from the rules is the difference between total inpatient hospital discharges and IPPS discharges. And then there's also an adjustment for the change in rates for the 2 midnight stay policy. And then also a factor for Medicaid expansion. And so the only thing I'd really like to highlight on this slide, because it will obviously make an impact on that factor 1, which is your starting point for the size of the entire pool. And so I've highlighted 2 values on this table, and those are the discharge percentages for fiscal year 2019 and 2020. Those are significantly less than those same years from the prior rule, as this is kind of one of the, probably the biggest reason, or one of the many reasons, why this year's factor 1 is less than the prior year. So what CMS stated in the rules or consideration is that discharge factor assumption is that they were attempting to factor how many beneficiaries will be enrolled in Medicare Advantage plans, and this appears to have negatively impacted the factor 1 size. And so moving forward kind of with the next slide. So as you can see, the 2021 estimate of what DISH would have been under the Affordable Care Act is 15.359, or I guess I should say absent the Affordable Care Act, is $15.359 billion. And so that compares to last year's rule of $16.583 billion. And so after adjusting for that empirically justified amount that's still paid out, the resulting factor 1 equals 11.519 billion, and that's 919 million less than last year's rule. So we can go to the next slide. This one gives you kind of a quick view of factor 1 since inception of the program in 2014. And so that you can see that every year factor 1 has increased until this proposed rule. And so where now instead of an increase, we see an almost, I think it amounts to about a 7% decrease in the factor 1 calculation. And so that leads us to factor 2 on the next slide. So factor 2, it's also known actually as the reduction factor. So this reduces the UC pool calculated in that factor 1 based on the change in the national uninsured rate. And so the result of this adjustment ultimately establishes the net uncompensated care pool to be distributed to those qualifying hospitals. And so the data used to derive this factor has kind of been subject to change since the UC program started. Sort of for the earlier years from 2014 through 2017, the data used to compute this factor was based on CBO data. However, in 2018, CMS chose an alternate source and began using uninsured estimates from the CMS Office of the Actuary report as part of the National Health Expenditure Account. So this new data source is actually more detailed, it's more complex, and it's supposed to be a better reflection of the number of actual uninsured in America versus that previously CBO data. And so CMS continued this 2018 change in the last 2 years and continues to use this new source for this 2021 calculation. So if we go to the next slide, you'll see that the CMS Office of the Actuary estimates that the uninsured rate in 2013 was 14%. That's about halfway down on the slide. And so for both calendar years, 2020 and 2021, the estimated uninsured rate was 9.5%. And so the calendar year values are then converted to a payment year using a weighted average approach. But obviously, since the estimated uninsured rate for 2020 and 2021 are the same, the weighted average is 9.5%. So kind of after running all of this through the formula that's shown up on the screen, factor 2 equals that 67.86%. And that's compared to the 2020 factor 2 of 67.14. So there's a slight increase in the computed estimate of uninsured rate for this year. And so what I'll point out, I think it's very important to note that the proposed rule was submitted to the Office of Management and Budget in, I think, January of 2020 for review and clearance. And it's pretty difficult to ascertain to what extent the projected uninsured rate was adjusted as a result of COVID-19 and the pandemic that we're all in right now. And so this is certainly an item that we hope that will be addressed in the CMS through the comment process, as one would expect that the uninsured rate, would increase significantly in 2021 compared to the most recent years based on just the current economic circumstances. And ultimately that should be reflected in this estimate. So moving forward, you can then, apply, so just going through this, you've got the factor 1, the factor 2, so you apply that 67.86% uninsured rate to the $11.519 billion in factor 1, and that derives an uncompensated care pool of $7.816 billion. And that'll be distributed to about 2,400 hospitals. So how does this compare to last year's rule? This actually represents a $534 million decrease versus the 2020 final rule. And so if we go to the next slide, I think you'll see kind of a trending perspective. I thought this was a good slide to show you just what's happening since the inception of the program, since 2014. You can see in 2014, there's around $9 billion. And then it steadily declined as the rate of uninsured declined in the U.S., or at least what was estimated using that CBO data. And then since the switch to the new metric for the uninsured, you can see in 2018, and obviously, some various other factors, it ticked up in 18 and 19, sort of with it being basically flat in 20 and 21. So the size of the pool, one of the reasons is the size of the pool increased as pre-ACA DISH estimates have increased when more current fiscal years are being used as the basis for computing the estimates of factor 1. But for 2021, we just covered that the pre-ACA DISH estimate went down for the first time since establishing that UC pool. And so that kind of brings us to factor 3, which is the next slide.
Yep, absolutely, Jonathan. And before we move on, Kiet asked a great question. He asked, what do you anticipate CMS will do about UC DISH calculations as a result of COVID's impact on unemployment and people losing coverage? And I think we'll touch on that a little bit, but I think Kiet, certainly from our perspective, and Jonathan, I'll have you weigh in as well. I think what we're going to see is that with the 1135 and other waivers that have been put into place because of the public health emergency, with people losing commercial coverage because of job loss and other items, I think what CMS is going to do is going to be heavily dependent on what the providers are doing in terms of Medicaid enrollment, identifying those individuals who qualify for charity care, and making sure that all of that information is getting to the best source possible and telling that story of what the demographics are of the patients that you're seeing. And Jonathan, I'd love to get your thoughts on that as well.
No, I totally agree. That was the one thing I was going to bring up. There's quite a few number of waivers that have been recently issued. And then I think what I just addressed is basically we would expect there would be some comments from providers and other entities about that change in uninsured rate, which ultimately affects the size of the entire UC pool. They're taking that billions and multiplying it by that 67%. One would think that change in uninsured rate that percentage should go way up, because obviously the uninsured should what we've seen through data is that obviously there's quite a bit more uninsured. So in the end, one would expect that the final rule may have a larger UC pool or to distribute to that 2,400 hospitals, and we'll just have to wait and see for the final rule to see how that plays out. But that's the way it sure looks like it should be. So factor 3. So this year, CMS is proposing to use federal 17 S10 data to derive that factor 3. And so this would apply to all hospitals except Indian Health and Puerto Rican hospitals. And so they are also proposing to use the definition of uncompensated care as reported on line 30 for fiscal year 2021 and all subsequent years. And just kind of as a refresher, line 30 includes both charity and bad debt, but does not include Medicaid or other indigent kind of program shortfalls. So it's just charity and bad debt as their definition of uncompensated care. And so for Indian and Puerto Rican hospitals, they continue to utilize kind of the 2013 Medicaid days and the most recent SSI days to calculate factor 3. One major point that CMS addresses in this rule is that they propose to use the most recent available single year audited S10 data for factor 3 in all subsequent years. And so that's obviously a signal that these S10 audits that have occurred in the last few years kind of pretty much are here to stay. And obviously they're going on right now for every DISH eligible hospital for their 2018 year. And so we expect these audits to continue. And so they go on to state that they expect the number of audits to increase, and obviously they've done that through these 2018s in future cost reporting years. As a result, believe the best available data will be from the S10 cost reporting years that have been audited. So this is just kind of an ongoing thing. And as we'll talk about later, CMS is currently auditing those 18 reports for all those hospitals. And like the last few years, they've audited about 600 of the 2,400 hospitals. And both 2 years ago and prior year, this year, they're auditing all 2,400 hospitals. It appears, or there's no indication that they would lessen that. So we would expect those audits just to continue forward for the foreseeable future. And then I think that brings us to our next polling question, if I have that right. So I think the question is your hospital's proposed UC payment an increase or decrease compared to federal fiscal year 2020? So there's either an increase, decrease, or unsure. I'll give a couple more seconds to let everyone vote. I mean, we see a lot of unsure, and obviously we can help you if you're obviously a Medicare DISH eligible hospital. Those factors and those are published tables, and you can have those impacts. We do also, it would make sense that we see an increase and decrease of a good mix, because obviously it depends on your hospital and the charity and bad debt you provide. Most of the time when we do these polls, there's a lot more decrease just because the size of the entire pool went down. So everyone's, the pie has gone down. So in proportion, the slice of the pie for each hospital typically goes down. So it's good to see at least some have an increase.
Yep, absolutely, Jonathan. I think one of the things you and I have seen as well is when CMS last year moved to the methodology to only use 1 year's worth of S10 data, there was a big shift for many states that had a heavy Medicaid expansion presence, where previously Medicaid and SSI ratio were being blended with worksheet S10. I think now that we're seeing 1 year's worth of S10 and everyone's being audited, it'll be interesting to see what the net effect of that is going forward.
Yep, I agree. So I won't spend a lot of time on these next two slides, as I think this impacts only a handful of providers, but I wanted to mention just a couple of other noteworthy items from the rule that touch on UC. One of them is about CMS is proposing a modification on the annualization of long cost reports, where the hospital has no cost reports starting in fiscal year used for factor 3 calculation. They're actually just going to use the cost report that spans both fiscal years. There's also a new section on all-inclusive rate providers whose UC costs are greater than 50% of total operating costs. They'd have their UC costs recalculated using a cost to charge ratio of the most recent prior year report that would cause that percentage to fall under that 50% threshold. And one of the other things is CMS is continuing with that cost to charge ratio trim methodology they established in 2018 for CCRs that fall outside of 3 standard deviations above the national average. And so if we go on to the next slide, there's just a few other things, and basically they're trying to, with all of these, trying to produce the most accurate data set that they obviously then are using to distribute these funds. And so one of them is that UC data trim methodology. They're continuing with trimming the UC costs for hospitals where UC costs are greater than 50% of the total operating charges. It's interesting to note that kind of the one caveat is that they will now only apply this trim if the hospital is not subject to an S10 audit. Well, obviously in this year, they're pretty much auditing every single Medicare DSH eligible hospital, but they go on to state in the rule that CMS feels that if a cost report was audited, there would be no need to apply a trim as the data has been reviewed through kind of the auditing of S10. And one thing to note in regards to calculating the interim uncompensated care payments, CMS is continuing to use the average of the 3 most recent discharges for setting those UC payments, but they're now proposing a voluntary process through which hospitals may request to lower their per discharge payment. So this process really should only be considered for significant recoupment, kind of such as anything more than 10% or more of the UC payment, or at least $100,000 on that. Because we have seen cases where that interim payments, just based on changes that the hospital knows, the actual interim payments can get way off than what's actually in the factor 3 calculation table. So that's something to look at to make sure that those interim uncompensated care payments make sense to the provider, and where there's a significant variance, that now you have this opportunity to lower it. So going on to the next slide, kind of another topic that came up with this rule that impacts S10 reporting is that we received some clarification with the topic of implicit price concessions as it relates to the accounting standards update, topic 606. And so based on that FASB update under topic 606, an amount representing a bad debt would no longer be considered, or no longer be reported, I should say, separately as an operating expense, but it's treated as an implicit price concession, and there is a reduction to patient revenue. So there was questions on how this would impact, or how this could impact, worksheet S10 and the reporting of bad debt, and would the implicit price concession be considered bad debt? And CMS actually addressed this, as they are proposing to recognize the topic 606 terminology, and these implicit price concessions will be recognized as bad debt on Medicare cost reports. So that's something to note going forward, that still is considered bad debt for the purposes of worksheet S10. And so for the next slide, I wanted to take a minute, kind of switch gears, take a few minutes to talk about the underlying data from these cost reports that determine a hospital's UC payment. Kind of earlier we discussed that the 2021 UC payment was derived from the 2017 cost report. And so I think it's a good idea to take some time to look at the results of the previous round of audits to see what kind of impact this ultimately had on the hospitals and their overall pool distribution, kind of especially in the light of all these 2018 audits that are going on right now. So the analysis we're reviewing today in HCRIS is the change in the federal 17 S10 reports that occurred between 10/1/19 and 3/31/20. And so these hospitals are all projected to qualify for UC reimbursement based on the 2021 rule. So just as I kind of mentioned, there was actually 650 audits that were performed during the 2017 review, and that CMS didn't disclose which hospitals were audited. But those audits would have been going on and would have been updated in HCRIS at the same time this pool is from. There's also, we know of, several hospitals obviously amended their cost reports at the same time. And so what ultimately you get to is 1,087 providers changed their line 30 during this time period. And so, and that line 30, like I mentioned, is the sole data point that's being used to distribute this uncompensated care pool form. And so what you can see from this, I think it's pretty telling, is that there's over $1.9 billion in UC costs that were removed from these S10 cost reports. That equates to about 7.5% from these 1,000 providers that were just removed from line 30, based on the audits, based on the updates, based on the amendments. So if we go on to the next slide, I just wanted to dive just a little deeper in a couple areas of what made up that 1.9 billion, because I think it's interesting to see, and I think it'll help you as you move forward with worksheet S10. So here we're showing the line 20 change in charity care charges, and as you can see, there's 651 of the 1,087 that have been updated. So collectively, just over 30 million was removed from the uninsured rate, and that's obviously an extremely small percentage. But I think the big takeaway on this slide is that change in the insured charity. Over 1.7 billion was removed. That actually equates to 41% of the dollars being removed from that line. And those insured charity dollars are not, based on the cost reporting instructions, they're not subject to the cost to charge. So every dollar removed from insured actually is a dollar for dollar impact on that line 30. And so I think there's a couple things. I think one, hospitals were going back and looking at that insured amount and looking at the instructions. I think another one is the max is a pretty big emphasis on that insured charity. The instructions actually call for that to only be related to coinsurance, deductible, and copay that charity discount is given. And I think it's pretty clear that there was some significant findings in that area, either by the hospital or through their own research or through the MAC, or in conjunction with the audit, I guess I should say. So if we keep moving along, there's also, this is line 22, and the only thing I'll mention on this is you can see that 268 providers changed their line 22. Line 22 is the patient payments that are reported for discounts that were given. And so what happened is the cost reporting instructions changed from 2017 forward. They were the first one under new instructions that basically the payments should be only related to discounts given. Previously, you would just report all the patient payments and charity would be full charges. So there was a difference in the methodology switch. And so what we saw here is a pretty significant change in that line 22 payment. Virtually 85% or more in both uninsured and insured being removed from those 268. Those are huge dollars being removed. And it, just like the insured, line 22 is not subject to the cost to charge ratio. So it again has a dollar for dollar impact on that line 30. So if we move on to the kind of the last piece that affects that line 30, it's bad debt. There was 628 of those 1,087 hospitals that revised their values for bad debt. Again, that change was massive. It's $3.2 billion, representing a little more than 11.5% removed from those S10 reports. And so I think there's a couple ideas on where that came from. I think one is the inclusion of bad debt sampling and a more robust bad debt review in these S10 audits. That happened in the 2017 S10 audits. Previous years did not have much of any bad debt reviews. We also know, kind of just from experience of reviewing filed reports, that some hospitals were still reporting bad debt from their provision, which in some cases can be considerably different than the actual bad debt write-offs. And so that's another reason for kind of, I think, the changes in these cost reports. And so if we go to the next slide, kind of in summary, what do all these numbers mean in actual UC reimbursement? Because I don't want that to get lost with all these changes that I just went over. This table summarizes the results of the changes from the 1,087 providers that we just walked through. And so, as you can see, the average impact is a loss of $426,000 in UC reimbursement. I put the largest and the smallest, or the largest increase and decrease also on this slide. You can see that there's some huge swings. So you saw one hospital, largest decrease having an approximate, I think, $52 million hit on the UC's reimbursement, and the largest increase equating to an almost $10 million pickup on the 2021 UC payments. So there's some huge varying changes just by amending or the audit happening on these cost reports based on the difference between their as filed and this revised numbers. And so as we move forward, so kind of what are the next steps? What are the best practices in regards to S10 preparation and kind of ultimately your UC distribution? I think the first thing to do is to review the data associated with the proposed rule, and obviously, look at that, make sure that it's correct, especially when the final rule comes out, make sure that's accurate and correct. As we mentioned earlier, MACs are currently performing worksheet S10 audits on all those federal 18 fiscal years. And so hospitals really need to designate an individual, or really a team of individuals, to prepare the S10 for filing and support during the audit process. These S10s take a considerable amount of time and resources to prepare. We know that at least for the 15 and 17, and really continue on with these 18s, the MACs have budgeted anywhere from 80 to 120 hours on each of these reviews. So to prepare an accurate S10 for filing, obviously, is going to take more time than even that. And then in order to, I would say, accurately report charity and bad debt, and to kind of optimize and maximize the uncompensated care report on S10, there really needs to be coordination between the designated S10 preparer and really the reimbursement staff, the revenue cycle, the accounting, potentially even policy, compliance, and or legal revisions if something's necessary with the policy. So that and also I'll say that designated S10 preparer will also need to stay abreast pretty much of any regulatory changes regarding the reporting of S10, along with the updates on audit findings to better prepare the hospital for future S10 reviews. There's just a lot going on with these S10s right now, and that's something that really needs to be looked at. That providers should take a look at that 2019s that they filed already, for presumably those are going to be audited for next round, so it's time to revisit those 2019. And then kind of just as a last note, I wanted to note that the requirement begins for cost reports starting on 10/1/18, that charity and charity care patient detail, along with actually even Medicare dish detail, is required at the time of cost report filing. If those details are not given, the charity care detail for worksheet S10 or even the Medicare dish detail, then it's subject to that cost report being rejected by the MAC. And then I think just kind of as the last thing, we talked a lot about UC, but it flows in with Medicare dish. We want to also mention that there is that filing deadline for Medicare dish. For an amendment, it's based on the OPPS rule. It's basically 12 months after the original as-filed cost report deadline. So you also have that kind of deadline to look at too, as it relates to Medicare dish, and then ultimately, obviously, your UC payment. So I think next slide. So I'll just quickly do this. I know we're kind of getting up on time. I just wanted to at least mention we have some resources on that slides. Just take a look. There's a lot of things that we're covering, whether it be COVID or some updating webinars, but I want to give at least a few minutes for questions. So I think it's time to kind of just see if there's any questions that you have. I know we can put those in the Q&A window, and we can go over those now if there's anything.
Yeah, certainly happy to answer any questions. Tremendous amount of information in an hour and a half. Obviously, I think that the key here, there's going to be a lot of changes coming up. Anticipating that Jonathan, I think from what we're seeing with the UC pool for, fiscal 21, we're looking at cost reports back in the 2017
Right.
timeframe. And so I think that one of the overarching pieces of this is that when activity is happening in the middle 6 months of 2020, obviously because of the lag in CMS's rulemaking, it very well could be that they start to speed it up to make sure that providers are taken care of. But always interesting to see too, as we've been talking about as a team, it really wasn't that long ago, and probably October, November of 2019, MedPAC comes out, the Medicare Trust Fund is going to be exhausted by 2022, and all of a sudden we have a pandemic hit, and there's accelerated and advanced payments, there's provider relief funds. So always interesting to see how the federal and state governments pivot in relation to what's impacting beneficiaries nationwide. So I think we're going to continue to see an evolution of that. Kiet, another great question, anticipating when the final rule will be published. Jonathan, I'm happy to have you speculate as well, but I think it's anybody's guess.
That's what I was just about to say, right?
Yeah. Unfortunately, Kiet, I think it very well could be a tight time frame. One of the other interesting items about them delaying the issuance of the final rule is for those providers who are attempting to submit geographic reclassification applications for wage index. They want to see the final rule before they submit their applications, and those are due here in the next week or so. So it'll be interesting to see just how the time frame is crunched on that. But we'll certainly keep the group here posted on these final rule updates, because I think, Jonathan, I know you and I have seen inpatient final rules that have been in the 1,500 page territory. I think there's going to be a tremendous amount of comments this year from providers. Yeah.
Well, thank you, Paul and Jonathan. Great having you. A lot of information, and I'm sure our members really appreciate it. And yes, it's a time of change that we're all going to be going through together. So again, on behalf of the Oregon, Washington, Alaska chapter, thank you for your presentation. Again, we want to thank all of our sponsors. We could not provide the education to our members without our sponsorship. So thank you for your ongoing support in our chapters. We're going to be posting a survey in this link very shortly. So please don't forget to take the session surveys as well. Again, there will be one on Friday in your email. So please watch for that. The session is in there. So please take the survey, and the next session begins at 1 o'clock. It is a separate link. So we hope that you can join us, and we'll see you then.